Okay, so we're going to talk about transfusion reactions today. We're going to talk about categories, and we're going to talk about the basic and the extended reaction workups. So, why avoid transfusing? We do not transfuse willy-nilly, and actually over the last several years, we've actually gotten better and better about transfusions. What we've done now is, used to be like somebody would be like, you know, hemoglobin of 8 or 9, and they'd be like, yeah, you can use a little bit, let's give you a little blood. Now they really wait until you're 6 because there are so many problems with transfusions that we don't want to just willy-nilly give blood because it's dangerous. For a period of time in the 80s, it was all about the HIV. Everybody was afraid of getting AIDS, right? That was the big worry. Well, that's the least of our worries. And some of the things you've learned about are the antibodies and things like that that our bodies produce now. That's really what we're more worried about. Our testing is really, really good for infectious diseases. We don't have to worry as much about that anymore. We still worry about it. We still do all the testing. We're still aware of it. But that's not really where the concern comes from as much as it does all the other things that can go wrong. So we avoid it because transfusions are dangerous. They can result in transfusion events, complications, and reactions. So there's 3 different categories, right? An event is the least serious, then it's a complication, then a reaction is the most serious. And we'll talk about all of those as we're going further. So we don't really want to give transfusions unless determined it's absolutely necessary. Usually what that's going to mean is somebody, their hemoglobin is dropping and they cannot raise it on their own. Okay? Their body is just not doing it. So we get our chronic transfusion of our like leukemia patients who aren't producing enough of their own red cells, things like that. Our sickle patients who we know that they're in crisis, they're going to need some blood, things like that. We don't just give it because, you lost a lot of blood, but your hemoglobin's still stable and you're healthy enough, we know it's going to come back up. So, a transfusion event. Any unfavorable effect caused by the administration of blood or blood components, so that can include plasma, platelets, cryo, anything like that, occurring in a patient during or following a transfusion. So, an event would include either a complication or reaction. You know, it's kind of like something that happens. A complication is an undesirable result of a blood transfusion not caused by an immune response. Okay? An immune response means we're dealing with antigens, antibodies, right? So, a transfusion complication is not caused by an immune response. Things like volume overload. We can give too much volume and cause congestive heart failure. We have to be careful. Citrate toxicity. What's citrate used for? Think back to phlebotomy.
Anticoagulant.
It's an anticoagulant. You give too much anticoagulant, we're going to have problems, right? So we put citrate in our units of blood because we can't give coagulated blood. But if we start giving too much citrate, what does citrate do? How does it work?
Chelates calcium.
Chelates calcium. Give a lot of blood, a lot of citrate, it starts chelating all your body's calcium. What's going to happen? Think back to A and P.
Brittle bones.
Long-term brittle bones, what about short-term? Where does the body use calcium? Muscles, right? Did you guys cover this in A and P?
Yeah.
Okay, a little bit? Okay. It's been a long time since I took it, and I took the other courses, but so it binds with that calcium. You need those calcium for those. Now, okay, I'm gonna step like over here because this is not my area, right? But calcium is needed for those neurotransmitters for your muscles to work right and all that. Okay, that's about as much as I know about that topic. But what's gonna happen is your muscles are gonna start contracting and not be able to uncontract. Okay, so you have to be kind of careful with citrate toxicity. People don't think about that. Iron overload. Give too many units, too much, you can get too much iron. Bacterial sepsis. Platelets in particular, we really worry about bacterial sepsis because platelets are kept at room temperature. But even in units of blood, you'll notice on those transfusion forms that we fill out, when you turn them out to the nurses, unit inspected, we have to okay it. We have to make sure it looks like a healthy unit of blood. Bacterial units, you will recognize they're really, really dark and ugly. So that's what we're worried about with bacterial sepsis. Infectious disease transmission, it still can happen. It's rarer, we've got much better testing, but it still can happen. And then alloimmunization, sensitization. We don't want to be sensitized to big E if we don't have big E, right? Because that can cause future problems. Yes?
Is culturing blood from donors something that we regularly do before we give? Or is it just, we're just going based on how it looks?
How it looks. Yeah, because cultures take 2 or 3 days, right? When we get to platelets, we'll talk about that. Sometimes culturing platelets has become kind of a thing, but platelets only have an outdate of 5 days, and a culture takes 2. So it's kind of harsh for units there. There are some faster tests. The problem is usually when there is sepsis involved, it's due to contamination during the draw, during the collection. That's why when we get to collections, we'll have an entire lecture on like what they do and how they do it. And they have to clean the site really, really well. And so you have to have really good phlebotomists that know what they're doing. Yeah.
So the last one is immune.
Alloimmunization. So what that means is like, let's say I don't have big E and I get blood that has big E, I could, my body's gonna become sensitized. I may not see a huge spike in the antibody, but that first sensitization, the second exposure is gonna be a huge spike.
Okay, so that's only complication.
That's only a complication. Sensitization is only a complication.
Isn't that still an immune response?
It is. It is. So it's kind of, but it's not.
Since it doesn't cause the symptoms,
Yeah.
it's just a complication.
Yes. Now on the next slide, we're going to talk about reactions. Okay. So on this side, this is where it's not that first exposure where you're getting exposed to it. You're actually getting. I almost pointed to the screen over here, like you guys can see that. You're actually getting the antibodies. The antibodies are going to be made. Try to figure out how to word that. Words are hard. Yeah.
I mean, would it be more comparable to like someone developing an allergy? The first time they eat it, they're not going to get a reaction, but the second time they eat it, they're going to get a reaction.
Yes. Very, very exactly. So that it's going to kind of like trigger the immune system. That's not really going to produce the allergies. It's not going to produce the antibodies. So yes, that's a really good way of thinking of it. It's just going to like stimulate it. It's just going to say, hey, whoa, we don't want to see that again. And when we see it again, it's like, woohoo! Now body's going to go into crazy mode. So, transfusion reaction, an undesirable result of blood transfusion caused by an immune process, which is an antigen-antibody reaction taking place. So now we actually have antibodies that are being made. Antibodies could be to red cells, white cells, platelets, or even plasma proteins. I gotta get a tissue. I need to remind me at some point to bring.
I know there's one of
I'm
those.
so sorry. Somebody just hand me one. Oh, are we out over here?
No, there should be one.
Oh, there's one left. Let me grab another left you up here.
There's a box of tissues in the room, right over there, though. That's
Where?
Across that wall.
Oh. Okay, somebody just remind me to bring your towels down next time you come down. Oh, here we go. I actually bought tissues the other day too, so it's becoming allergy season. So my eyes are drooping, my nose is drooping, so I apologize, guys. So, okay. So, with regards to all this, the FDA regulations, so there's a lot of different blood bank licensing organizations are requiring blood banks to have written procedures to detect and monitor transfusion reactions. So it must be written out, like how they're going to detect it, what they're going to do, what the processes are going to include. Like even with the nurses, so remember a couple weeks ago, the nurses that missed all those signs, we read those articles? Those are the types of things that are written, like in their nursing policies. The blood bank actually is involved in nursing policies, like what to watch for, because they have to follow these rules per FDA regulations. The fact that they missed so many problems, they took all those shortcuts. Both nurses took all those shortcuts, did all those bypasses, and because of that, we ended up having a problem. So the FDA in particular, they're the ones that come down hard on a blood bank. But there's lots of other blood bank licensing agencies. You can be regulated by the AABB, JCO, CAP, all those different organizations we've talked about. Lots of rules throughout all of them. Usually AABB and the FDA are gonna have most of the guidelines set, and CAP and JACO, they're gonna go, yep, those are the guidelines, you know, because they're the specialist in blood bank. Any transfusion resulting in a fatality must be reported to the FDA within 24 hours. So anytime a transfusion results in a fatality, those cases that we sent you, for example, one of them was in the UK. So the UK obviously is not controlled by the FDA, right? But they have their own
Acronym.
something. Yeah, I don't know what theirs is, because the UK is, maybe it's part of the European one, I don't know. But anyway, they have their own kind of agencies, but it's the same idea, because it shouldn't happen. Because most of the time, fatalities mean you're missing signs of problems, you're not stopping the reaction, and most of the time it's an ABO incompatibility problem that should not have been missed. Blood transfusions should not cause death. So kinds of reactions, we can have hemolytic reactions, either acute intravascular or a delayed. Which one's most commonly caused the delayed? Kid, yeah. But there's also non-hemolytic types of reactions. These are usually ones that are not preventable. We don't know they're going to happen. Allergic, febrile, anaphylactic, and then TRALI. And we'll talk about each of those. Allergic is the more mild form of anaphylaxis. Anaphylaxis is where you start having severe breathing difficulties and inflammation and things like that. Allergies, you start with the hives. That's actually going to be one of our most common transfusion reactions we're going to see is like allergies, development of hives. People are allergic to one of the additives. You know, the way I kind of like explain to students to kind of help you remember, I'm allergic to bananas, I got blood, and the person had bananas that morning. Is it that direct? Probably not. But, you know, it's that kind of thing. Allergic reactions are really easy. If people tend to have a lot of allergies, they're going to give them a boost of Benadryl before the transfusion. If it's coming through and it looks like allergies, they still stop the transfusion, go through a whole reaction process just to make sure. If it turns out it was just allergies, give the Benadryl, continue the transfusion, and they put it in their files, and then they know in the future they start getting allergic reactions. We can treat it as an allergy until things don't look like allergies. So symptoms, mild to moderate, fever and chills, drop or rise in blood pressure. It could go either way. Remember we talked about when you first give the blood, they do a pre-transfusion blood pressure, temperature, pulse, and respirations. I think of all four of them quick. They do those before and 15 minutes after and then regularly throughout. They have to do all four, and you're looking for changes in those four. So depending on how your body reacts, it could drop or it could rise, or it could rise and suddenly drop. You know, it could be all over the place. We're looking for changes. Dyspnea, any sort of shortness of breath. Urticaria, rash, hives, general redness of the skin, things like that. Nausea and or vomiting, wheezing, rales. Rales is another type of it's rattles in the chest, so they sound funny when they breathe. We're not respiratory therapists. If they sound funny when they breathe, that's an issue, okay? I'm not going to make you guys determine what's the difference between a wheeze and a rail, okay? Capillary oozing. So they start like oozing outside of their sides. Any open sores ooze, they start getting bruising, things like that. Capillary oozing. Pain at the site of infusion. Lumbar pain, that's kidneys, right? Back here. Extreme anxiety. We talked about this before, right? Your body knows something's wrong. Your body knows it, and so your anxiety is going to spike. And production of red urine. Okay? When you see the red urine, you're at the top of the moderate. You're getting towards the severe. So it's really important to notice that. You hit the severe symptoms: renal failure, respiratory arrest, cardiac arrest, shock, DIC, which is disseminated intravascular coagulopathy, and death. So these are the more severe. So the nursing role. Nurses must take vitals before transfusion, as I just talked about this a couple slides ago. 4, temperature, blood pressure, pulse, and respirations. Repeat it 10 to 15 minutes, and then monitor periodically after that. One of those cases I gave you, she was randomly doing vitals. I think it was the St. Luke's one. Did they talk about, that might have been in my big full case I have. I don't think I gave you guys that one. But they didn't do all 4 vitals regularly, they just randomly, oh, I just did a pulse. A little bit later, oh, I just did a blood pressure. You know, they weren't regularly doing all 4 throughout the process, and that's how it got missed. If a patient shows any of those symptoms, mild to moderate, anything, something just seems off, stop the transfusion. If you have a nurse that calls you and says, I'm giving this blood and I don't know what to, stop the transfusion. Just stop them right there, stop the transfusion, and let's talk. Do not keep giving it while we're talking, right? Stop the transfusion. Immediately they have to alert the patient's doctor, whoever's monitoring that patient, right? Initiate any medical intervention. Obviously, if they quit breathing, start breathing for them, right? You know, if it's an allergy site symptoms, if it's anaphylaxis, you're gonna give epi, FEBRILE, whatever. So you're gonna take care of that. Record the vital signs at that moment so you can compare and know where they're at that moment. Report any symptoms they're having. So what symptoms are they having? Do you guys have labs with you today? Look at your blood bank order form. The big one. So this is just a smaller version of what the nurses will have. But on the bottom here, you can see where they keep track of the vitals. We've talked about that. And then it's recipient response to transfusion. There's lots of boxes for them to mark there. And then there's a spot that says reaction form initiated. So there's a special reaction form they have to fill out. And then the empty bag returned to the blood bank. It may not even be empty. It may still be a full bag. It may be a partial bag. That's okay too. But that's where this is our copy of the form where they can kind of keep some general information for this. But it's pretty, I mean, it's a pretty intense form online. You know, it's all online now, but they go through and they have to mark all these things, like what are they seeing? So when they send it to us, we can look at it, and then this all goes to the pathologist to look at the end, which we'll talk about in a little bit. So they're gonna report the symptoms on the form. They're gonna obtain a blood samples. We want an EDTA and a red top at this point, and obtain a urine sample. Yes?
With that blood draw, would it be done on the same side that the transfusion is happening, or the opposite?
It doesn't matter. Probably the other side would be easy. It depends on where they have IVs.
Right.
As long as everything's stopped, you know, we're gonna stop the blood. And if it was on that same side, they'd have to pull it from the IV, which we get a hemolytic possible response. Have you guys ever seen them draw from an IV where they stop the fluid and they actually draw the blood from their IV? It's nice for the patient. It's one less stick, but it's more likely to be hemolyzed. And when we're dealing with this, is the hemolysis from the draw, or is it going on intravascularly? What's happening? And so we really don't want them drawing from the actual IV. We want them drawing a peripheral stick because we want a good sample to know what's going on in the situation. So the nurses must then send to the blood bank the blood samples, the urine sample, the donor bag, so that whatever blood is left, they're going to send it to us. Any IV tubing and solutions. There's only one solution you're allowed to give blood with, and that is normal saline. They have to send it all to us. So literally they unhook it from the patient and everything comes to us. Paperwork, they must send back the unit tag that's attached to the bag that they're filling out. A lot of times these are stickers that print off now. They're attached to the bag. The transfusion slip, that's his blood bank order form with all their information about the transfusion. Again, this is all computerized, but they're gonna have to make sure we get it. And the transfusion reaction report form, which I don't actually have pretty much with us. It's just this bottom part, okay? So in the blood bank, first thing we're gonna do, if they call us and tell us it's coming, or once it gets to the lab, we're gonna notify the pathologist on call, whoever the pathologists are, because they're the ones that make the final call with all of this. No blood is allowed to be given until that pathologist makes the call and says it's okay to give some more blood. We can't determine the type of reaction based on symptoms alone. We have to do some testing to find out, was it just a slight allergic reaction? Was it citrate overload, or are they having a serious issue? All the basic workup gets done on all transfusions, regardless of what the symptoms are. And any sort of time you get a transfusion reaction workup, the basic workup is done stat. Okay? Basic workup is designed to detect hemolytic transfusion reactions, but most of the reactions we're going to get are not going to be hemolytic transfusion reactions. Most of the time, you're going to be able to get through the basic, nothing's going to happen, it's all going to be negative, and you're going to be able to pass it out. It's not going to be anything that we can do anything about. Most of them are not due to those antibodies to red cells, and therefore are not considered hemolytic reactions. So the basic workup, I handed this form out to everybody. Did everybody here get one? Did anybody come late and not get one? Okay. The basic workup consists of a clerical check. First thing we're going to do is we're going to look at every label. We're going to look at the sample. So the original sample, the patient sample that was initially drawn. We're going to look at the unit tag and the worksheet. So this is the worksheet where we're showing all of our work, right? So we're going to go to the file and we're going to pull all this information and we're going to compare it. And you can see there's a place to write the name and MR number. What I expect you to do is look at the sample, write the name and the MR number. Then you're going to look at the unit tag, write the name and the MR number. Then you're going to look at the worksheet, write the name and MR number. Do not look at the sample and write it and just copy it in all 3 spots. It makes sense, right? Because we're checking to make sure. Do these all match the initial person?
So,
Yeah,
so all 6 boxes should essentially be the same thing.
they should be.
Yeah.
So once you get all 6 boxes filled out, you're going to look at them and make sure they're the same thing. But you don't want to look at one and just copy it over because you won't find a mistake. Donor unit number. We're going to look at the donor badge. In this situation, it's going to be that white tag that's on the little units. Which reminds me, when you're taping your unit tags onto here, do not tape over that white piece of paper. Because when we take it back off, that tape, we tear that white piece of paper off. And we need that white piece of paper on. You want to tape it over the plastic tubing, not the white tag. Does that make sense? Okay. You're going to look, so you're going to look at the actual donor unit. You're going to look at what was written on this form, the unit tag, and you're going to check what was written on the worksheet. You're going to write all those down and make sure they all match. After that, if they all match, you move on to the next step. Visual check for hemolysis. Does anything look bad? How do things look? You're going to look for the pre-sample. You're going to look at the post-sample. You're going to look at the donor badge, and you're going to look at the urine. Now, a lot of times urine goes to chemistry or someplace else in the lab. It doesn't really come to the blood bank because we don't do urines in the blood bank. And at UW, the blood bank is a completely different floor than the rest of the lab. So we may have to look at the computer to look for hemolysis. Next week with me, I will give you guys the results of the urine on the board. You'll have the result. If I forget, remind me. But I'll put the results of the urinalysis up on the board so you'll have a chance to see what the results were. The next step is going to be the DAT. And you can see, I'm going to kind of skip that on our paper. It says the ABRH typing of the post. I'm going to bop down to the ADAT. Because there's incubations involved. We will be doing, that's what I have to write, DAT. Friday during open lab, we're going to be doing DATs. And you'll have 2 to do during open lab. And that'll get you ready for next week's lab. Because this lab takes kind of a long time. And we tried last year doing the DATs on the same day. And everybody was so confused and frustrated. What should have taken a half an hour took like 2. So we're going to do them ahead of time during open lab this week. We're going to repeat the ABO check of the, you can see here it says post sample, so post transfusion reaction. Now, I guess I should say, is the pre-transfusion reaction sample going to say pre-transfusion reaction? What's going to be ordered on that sample?
On the screen.
Type in a cross match. Okay? It's not going to say, because nobody's expecting a transfusion reaction. I've had people looking for, well, I can't find the pre-transfusion reaction. Well, it's going to say type in a cross match. Post-transfusion reaction is going to say TXRX in or something like that. It's gonna say transfusion reaction because that's what's being ordered on that. So, so we talked about all this, I'm gonna go through it piece by piece. Clerical check, donor unit. Was the donor unit properly tagged? Did we put the right label on the right unit? Did we issue the right blood for the right patient? This is why nurses, when they come in the door to get blood, can only get one person's blood at a time to make sure, oh no, the tags fell off. It doesn't matter the voltage pauses, I'm gonna flip them, right? Was that blood given to the right patient? That one case in the UK, the wrong blood was given to the wrong patient. The case down in Texas, it was a problem with the wrong patient's blood that got tagged across matched. So hemolysis, we're gonna do a visual check. Compare the pre-transfusion, any sort of pink or red. Now, we know that bad sticks can cause it too. So we kind of have to be aware of that as we're going through, like, is it really a, hemolytic, what's happening? If hemolysis is present, we're gonna check for the traumatic stick. We're gonna ask for another stick. Also, we're gonna check for hemolysis in the donor bag and or the IV tubing you get. Because we're gonna get this whole pile of tubing and stuff you're gonna be going through. Repeat the ABO on the post-transfusion sample. In the situation in Texas, if they had stopped the transfusion immediately like they should have and gotten to the basic, they would have found that ABO was wrong on that patient. They could have saved her right then and there, but they didn't stop it. If the type does not match the pre-transfusion, then we have to grab the pre-transfusion sample and redo it. That's part of our extended workup we'll get to, but that's kind of our first, whoa, what just happened there, right? So we're gonna look at the pre-transfusion. Did we mess it up on our end, or was it messed up before it got to us? Very seldom is it a lab problem, because we have so many safety devices in place, right? Our reagents are always in the same order. Our tubes and our racks are always in the same order. We always put all the clear in first. We always report them out in order. We do the A, the B, the AB, the A1C, the BC, the D, and the DC. We always do those. We read them in order and record them in order. Read one tube, record one tube. Very, very seldom is it a lab problem. If the pre-transfusion sample is a different one, we're going to have the patient redrawn. Repeat the ABO and RH on all samples during that time frame, because maybe the nurse has mislabeled the other way. Maybe the label went on the wrong tube. So let's say, Charlie's in bed 1 and Jillian's in bed 2, but you were all on the floor that day and you all had transfusions ordered. I need to know whose samples got mixed up. So we're going to redo everybody that had transfusions ordered in that time frame. It could be problematic, right? If we have one mix up, we know. If you have one, you know there's more than one most of the time. You know somebody else is switched around somewhere. For the DAT, we're going to look for mixed field reactions. What that's looking for is the donor population. We have antibodies against those donor cells, but the patient cells aren't going to be reacting is what we're primarily looking for. So because of this, it may only be positive microscopically. So we look at these macroscopically using our mirrors and our lighted agglutination viewers, but then we also put a drop on a slide with a cover slip and look at it microscopically also to look for agglutination microscopically. We should only see, as I said, the transfused donor cells should be the only ones reacting because we're not expecting an auto issue, we're expecting an allo issue. If it is positive, then we're going to compare it and do a pre-transfusion sample. Make sure it is because of the transfusion and not something that's allo immunization. I'm sorry, not something that's auto, pardon me backwards, auto immunization. If it is positive, then we're going to do an elution. And we're going to elute the antibody from the cell. So what we're pretty much doing is we're taking the cells and we want to find what antibodies are coating the cells. And so we're going to break that bond, pull the antibodies off, and then test that. Urine hemoglobin, we're going to do a dipstick. Actually, chemistry or heme is going to do the dipstick. We're going to look up the results. If it's positive, we want to know, do we have intact red cells? Intact red cells are less significant than the hemoglobin. We're really interested in hemoglobinuria, not bleeding, but it might be hard to tell because even if there are red cells, there could be red cells there due to something else. We can't say, oh, it's not hemoglobin. If the basic workup is negative, we're good, we're done. If everything is good, if all your clerical checks are good, your DATs are negative, your RH typing is good, you're good to go. We don't have to do anything more at that point. But you still have to wait for the pathologist to give the okay. So you'll call the pathologist, I'm done with the workup, they're gonna look at everything, and they're gonna review at that time the patient's chart, they're gonna look at all the symptoms, review the lab results, and then they're gonna talk to the patient's MD or the transfusionist, whoever's doing the blood, and they're gonna make the decision, are we good to go? Or do you have to have more testing? It could be that they're gonna end up ordering more testing for some reason. You know, they could say, this just doesn't look right. Pathologists are like crazy smart, okay? I think we've talked about pathologists before. Crazy, crazy smart. They may see something that we have no clue about, or we may see something and say, hey, we think this looks weird, you know? And they might say, yeah, you're right, and they may end up ordering something else. So just, they make the rules, so we follow what they say. If any part of the basic workup is positive, so something didn't work for the clerical, that's my biggest nightmare. Clerical problems are like my biggest nightmare because that's a big problem. If the DAT is positive, if the ABO is wrong, anything else, if anything is positive, we immediately notify the pathologist, and then they'll notify the patient's physician because the physician's going to be getting on our behinds because they want that blood back. What's taking us so long? They don't understand that it's not a matter of like pushing a button and getting an answer in 5 minutes. This is very, very time consuming. So the pathologist will be in touch with the patient's physicians for us, and we'll begin the extended workup. So in the extended workup, that's page 2, and I have to laugh, this one line got put on the second page for these, and I'm like, I'm not throwing them away, so we all have 2 pages. So on page 2, we start with this workup. We're going to repeat the ABLRH on the pre-transfusion sample and on the donor unit. Now, the Red Cross checked it. We checked it when it came in before we did our cross match, but we're going to double check it because it's just, again, it's just checking that box, making sure we've done right. We're going to go back to the pre-transfusion sample that's going to be labeled check a cross match and check it just to make sure. We're going to repeat the antibody screen on both the pre and the post transfusion. We're going to repeat the cross match, but we're going to take it all the way through HG, whether it was through HG before or not. We're going to take it all the way through HG. Because obviously something went wrong, right? And when do we carry a cross match to HG? When there's something wrong. So we're going to, most of the time we only do the immediate spin, but at this point we're going to repeat it and carry it all the way through. Did something get missed? Most of the time, it's not going to be a problem on the pre-transfusion. Sometimes on the post-transfusion, if there's enough antibody formed. So let's say I had a transfusion 4 years ago, got exposed to D, I made anti-big D, but the titer was really low, so my pre-transfusions showed no titer. I've never had a reaction. I've never had a history of anything. So they're going to do an immediate spin cross match. They're going to give me more blood. My titer's going to spike, but there may not be enough antibody floating around in my system. It might all be attached to those red cells. So my post-antibody screen and my post-cross match might still be negative, which is why we do the DAT, and we're going to loot off the cells, any of the antibody that's attached to those red cells. Those antibodies might all be bound by those red cells in the body. So, as I said, the DAT is positive, we're going to loot the antibody to it. So what we do is we take the patient's EDTA tube, we're going to wash it multiple times with a special wash solution because we want to remove all the plasma antibodies, anything that's free-floating, all those free-floating plasma proteins. We want to remove all of that, so we're going to wash it multiple times with a special wash solution. Then the red cells are going to be treated with an acid, and when we give it the acid, what it's going to do is unbind any of the bound antibodies. So remember, they kind of like it slightly basic. In order for that, remember if we talk back to like how antibodies are attracted to red cells, they kind of like it a little basic. We're going to add an acid, and when you add the acid, it's going to break those bonds without destroying the antibodies. So then what we're going to do is we're going to spin it down, and all the acid eluate is going to be the supernatant, and we're going to pull that off. But then what we're gonna have to do is take that acidic pH and make it basic again. Because what's gonna happen if I left it acidic and tried to get it to respond to antibody screening cells, it's acidic, it's not gonna react. So we bring it back basic to make it react, and then we're going to test it against a panel or the screen. It depends on what we think we have going on in AB cells. So if we have the eluate, and if at that point all the cells are negative, it could be an antibody to medications. So the DHT will be positive for antibody, but it's not due to a red cell antigen. It could be due to a medication. Or some sort of a non-specific absorption of a plasma protein. So some plasma proteins somehow absorbed onto the red cells and were causing the problem. If all cells are positive, we're looking at an autoantibody, like, autoantibody I, for example. We've seen what that looks like on the panels. If only the A or the B cells are positive, we're looking at the ABO antibody. Very seldom do we see an ABO problem, but when we do, it's a big problem. We usually will see that with moms. We talk about HDN in a couple weeks. That's going to be our most common. It's going to be our ABO antibodies. Or most of the time, if it is truly an reaction, we're going to see a pattern. And what that means is we're going to have pluses and negatives along the pattern, and we're going to do cross-offs, just like a regular antibody ID. So we're going to end up identifying the antibody, and it could be either extravascular or a delayed hemolytic transfusion. Additional testing that pathologists might ask for or might be required, just depending on the situation. Additional testing we may see. A gram-staining culture of the donor bag. If we think, maybe there's something going on there, we could gram-stain culture the bag. Cultures are going to take a couple days, so we may not get an answer. We're going to look for HLA, which are white cell antibodies. Look for antibodies to IgA. We have patients that have IgA deficiencies. Blood transfusions can be harsh on them. We have to give them washed cells to make sure we're not giving them IgA. We're going to look for other signs of hemolysis: decreased haptoglobin, elevated bilirubin, increased LDH, increased reticulocytes, or any sort of an abnormal smear. The spherocytes, the schistocytes / kite cells, we're going to see things like that. So we're going to look for other signs of what might be happening. So an acute intravascular hemolytic transfusion reaction is going to occur within minutes or hours of a blood transfusion. Okay, very uncommon. We're not going to see these very often. Most of the times, it's going to be an ABO issue when we see these, and it's going to be fast and hard. Could possibly also be caused by a high titer alloantibody. But if it's a high titer alloantibody, we should have caught it in the screen, and we should be giving antigen negative blood. So usually that's not going to be our problem. Symptoms we're going to see: a spike in temperature, a sudden drop in blood pressure, back pain in the lumbar area because the kidneys are working trying to get all that extra hemoglobin out, pain at the infusion site, labored breathing, extreme anxiety. They're going to be going into renal failure, and this may result in death, especially if it's ABO antibody. I'm going to go back 2 slides. This alloantibody titer. When would be a time that we may not catch a high titer alloantibody on a screen before we give a transfusion?
A new antibody that's made.
A new antibody shouldn't be a high titer yet.
Okay.
So close.
Goes away during pregnancy.
No,
Or one that's not detectable,
no.
and then.
So high titer means we're going to find it on an antibody screen. That's what high titer is, right? The antibody is so high, we're going to find it on an antibody screen. When might we see this as a problem?
Post-zone?
Hmm?
Is it like the post-zone effect or something?
No, we shouldn't see that. Emergency blood release. So, O negatives, right? Emergency blood trauma.
Oh, immediate. Okay.
We give an
Because you don't have
uncross-matched, unscreened, untyped We haven't looked at the patient at all, and we're just throwing old blood at them
And hoping it works.
and hoping it works.
Okay.
Yeah. This is why we do not like giving emergency release, right? People who aren't in blood bank don't understand, oh, it's O negative, it's fine, it's safe. You guys have learned enough now to know that's not true, right? So that's what we're talking about. They would have us high titer, but we don't have a chance to get through the screen because they're sending blood out and giving the blood before we get through it. Then all of a sudden the screen turns positive and we're like, oh, you know, I'm calling them saying, slow down, don't give us money. You know, we're trying to get them to stop it. And thankfully when we send it out, we save those little segments so we know what we gave them. And we can type to see which units are safe as fast as we can, but that takes time. And meanwhile, remember that the kid, that first week of class, I showed the video of the kid that cut his femoral artery? He got a ton of blood. Thankfully, he didn't have any antibodies, right? Because he had a ton of blood before they were able to type and cross-match. He was on his way to the second hospital before that type and cross-match and screen got done. So that's when we're gonna worry about this more than anything. Most of the time, we're not gonna see this. Okay, so we've seen this picture before. We're gonna talk about it again. Acute intravascular hemolysis. We have our donor cells, our recipient complement fixing antibody. They're gonna bind, their complement's gonna activate, it's gonna hemolyze the red cells. Intravascular hemolysis, we're gonna have red plasma and red urine. Patient antibody reacts with donor cells, activates complement, complex cascade, goes through MAC, destroys all the cells. Donor cells only. It's not going to affect the patient cells. So again, if we see symptoms, we're going to stop it fast. We're going to stop that reaction because the less we give them, the better it is. So basic workup of an acute IV hemolysis, the clerical check may show the wrong blood was issued or the wrong patient was given the blood. Excuse me. Visual check may show pink or red plasma. ABO type may not match the pre-transfusion type. DAT may be positive for complement and or IgG. Or the DAT could be negative because all those donor cells that were coded have now hemolyzed. I'm going to tell you, I've never had a true reaction, and most of my former students that work in blood bank, I don't know that anybody's ever had. They've gone through the process, but it's never been a true hemolytic reaction. Thank goodness. Yeah.
Does that mean they normally stop at the DAT? Like the DAT isn't positive?
The DAT would be negative, but because of like signs and symptoms, the pathologist would have you go on. Well, actually, the red urine would be your clue to go on, and hemolysis would be your clue to go on. Probably more than anything. I tend to err on the side of caution, and I would probably just kind of like start those next steps until I heard back from the pathologist to save the time, just to keep going.
In an ideal situation, the DAT is negative and we don't have to go full.
Yep. Ideal situation, 99.9% of the time, clerical check works. The post-ABO matches what you have on the records. Urine's clean, plasma's clear, DAT's negative. They were allergic to the bananas. Because I'm being a little glib there, but you know what I'm saying. You know, it's an allergic reaction. It's a white cell reaction. Actually, we're talking about white cells. Most of the time, it's white cells. Extended workups on the acute intravascular hemolysis. We're going to repeat the antibody screen. It may show the presence of a clinically significant antibody. But remember, it would have to be a high enough titer of an antibody to be free-floating in the plasma and bound on those red cells. So the antibody would have to go up high enough, fast enough to actually be floating around free in the plasma for the screen to be positive. The repeat cross-match is more likely going to be incompatible at that point. If the screen's positive, now the cross-match is going to be incompatible. The ELUATE may show the clinically significant IgG antibody or an ABO antibody, depending on what we have going on.
I have a question.
Yes.
You had previously said that we take the repeat cross match through AHG. Would you also do the antibody screen through AHG?
Antibody screens always go through AHG,
Oh, right.
right?
Yeah.
So, yep, you are, yes, we would. So, because they always go through, good. Delayed, now let's talk about the delayed. 7 to 14 days later, okay? Does not present as an identifiable event. Patient just gradually starts developing symptoms. They start getting tired, don't feel well, get a little lethargic. These are caused by secondary or amnesic responses. The antibody titer was so low that it was undetectable in the initial screen. The antigen-positive donor blood was transfused. The antibody titer was re-stimulated. And we're going to start possibly seeing problems longer term. So, delayed donor red cells, non-complement fixing antibody. The IgG coats the red cells, and then the liver and the spleen are going to sequester. We're going to end up with yellow plasma, yellow urine, because the liver and the spleen are just kind of saying, yeah, I'll take that, taking little bites out of the cells, pulling them out of the system.
More yellow than normal?
No, normal yellow. Yeah, good question. Normal. No, instead of being yellow, it should be normal, but we always think normal. It's not red. It's not pink. Symptoms include fever, fatigue. They may get a little jaundice, depending on how much blood they got that's reacting. They may end up with a little bit of jaundice. Maybe some lumbar pain, not as much. Rarely are these going to be fatal. There have been stories about, like in Arizona, a lot of times these, patients, they get routine, blood transfusions due to like older patients that just can't keep up and whatever. We get a transfusion before they go off to the snowbird to Arizona. They get to Arizona, within 2 weeks they have these problems. And I just don't feel good. I don't know what's going on. If you had a transfusion the day before you left, 2 weeks later, now you're sick. So that's kind of what we see with those. Lab work, you're going to see a gradually falling hematocrit, nice and slow. Bilirubin LDH should be gradually increasing. Neither of these might look critical, so you may not even notice it. If you don't have access to their labs here and they're down in Arizona, you may not even notice a difference. Peripheral smear may show some spherocytes, tryptocytes, and reticulocytes, but in the elderly population, may not be quite as abnormal. Elderly people, things happen in life. Things happen with their labs, so sometimes that might be more normal for that population. So instead of a transfusion reaction workup, a lot of times they're going to just request a direct and an indirect Coombs. Now, depending on where you are, they all have slightly different names, right? Pretty much we do a DAT and an IAT. So DAT, IAT. What's an indirect test? What's the other word we use for it? Indirect antibody testing. You've done it every week for the last 6 weeks. Antibody screen. That's your indirect. The order, it's an indirect Coombs. It's just an antibody screen. That's what we call it at the blood bank. Antibody screen may be positive or negative. The titer may just be so low it might not be detected. Or if it's attached to all those red cells, and all those red cells have all the, because if it's going through the liver and spleen, they're going to bite the antibody off the red cells, right? So it may not even be there. The DAT is likely to be positive still, though. The clinically significant IgG blood group antibody would be found in the ELUATE then. So now we're going to talk about some of the non-hemolytic transfusion reactions. Allergic, febrile, anaphylactic, and TRALI. So allergic reactions, fairly common, okay? Caused by patient IgE antibody reacting with the soluble allergen in the donor blood. Now, I don't know if bananas are truly a soluble antigen, okay? But I just talk about bananas because, you have to talk about something, right? Maybe peanuts, I don't know, are peanuts soluble? That's not my area of expertise, I'm not really sure. So we have soluble antigen in the donor blood. The recipient, histamines are going to be released. They're going to get rashes and hives, itching, watery nose, runny nose. These are not fatal. They're annoying and not comfortable, but they're not fatal. If there's no change in the vital signs and they're just getting this urticaria, rash, or redness, they do not have to work up as a transfusion reaction. Temporarily, they're going to stop the transfusion. They're going to give some Benadryl. And then once those symptoms kind of go away, they can start the transfusion back up. And a lot of times these patients will be, especially if we know they're prone to this, are going to be pre-medicated with Benadryl before it. Yeah.
Because the antibodies are, I guess, never mind, I think I answered my own question.
Okay. Oftentimes with allergic reactions, they are worked up the first time just to make sure. We're gonna go through this basic first page workup. It's all gonna be good. We're gonna send it back. They're gonna get a note in their file, allergic reaction, and then they'll know for future that, yeah, they're prone to allergic reactions. If there's any change to a vital sign, transfusion gets stopped and we do a workup. Even if they have a history of allergies, the minute there's a vital sign change, we work it up. At that point, basic workup should be negative. We should be, yep, good to go, and send on. We don't want to ever assume. It's just like we never assume an autoantibody is all that's there. It could be hiding an alloantibody. We never want to assume that it's just an allergic reaction because it could be hiding something more severe. Anaphylactic transfusion reactions, extreme form of allergic reactions. They are rare, but very serious when they happen. They can be fatal. Your airway can swell. It may close off. Pulse becomes rapid and weak. Blood pressure starts to drop, and the patient can go into shock. So these are bad things. Maybe seen in patients who are deficient in IgA and have made an IgE to an IgA. So in basic immune concepts, you guys talked about IgA deficiencies at some point.
Yeah.
So if you get blood with normal IgA, that can cause big problems. So that's why when we get to units, some of those units we washed. Only a few cc's of donor plasma containing normal levels of IgA can trigger a severe anaphylactic reaction. So what we end up doing is we find donors that are IgA deficient and we collect their plasma and save it, and so we can give IgA deficient plasma to these patients. Most of the time people are aware of an IgA deficiency, thankfully. That you'll have immunology workup done, immunoglobulin levels are low, they're chronically ill, they have things like that. Basic transfusion workups in this situation are going to be negative. There's nothing, there's no autoantibodies or alloantibodies that are affecting it. It's what it is. Pathologists may order IgA levels. Remember I said pathologists may order other tests. This is one of them. They may decide, let's just double check and order the IgA levels and test for IgA antibodies if not already done. If we are going to transfuse patients with known IgA antibody deficiencies, best blood is their own, autologous. But I think we talked about that already. Did we talk about why you don't like to give autologous blood? Because you're already starting out a unit or two low before the procedure. If autologous is not an option, washing the red cells to remove all that extra plasma. Because when we go into collections, I'll show some videos of how collections are done. And when we get packed red cells, they still have some amount, I think it's about a 70-ish, 75% crit. So there's still some amount of plasma. And what we want to do is wash and remove all that plasma. We're going to transfuse IgA deficient people. Or, like I said, find plasma from when we're giving plasma, then we're going to find plasma from an IgA deficient donor. Usually the Red Cross will have some of these in the freezer ready to go. Places like UW probably have some in the freezer, just because they have such, some of their clinics are kind of out there and what they have, so I wouldn't surprise me if they had them in their freezer, but the Red Cross will have them, and if there is a shortage, they'll make some calls to some of the rare donors. Febrile reactions are super common, characterized by a temperature change of at least 1 degree Celsius, maybe accompanied by chills, shaking, nausea. It's unpleasant, but it's not fatal. Most of the time, this is actually caused by the patient antibody to the white cells, antigens, granulocytes usually. Very common in multiply transfused patients. Granulocytes are more immunogenic than red cells, and the antigen antibody reactions to white cells cause them to degranulate and release cytokines and pyrogens, and then those are going to create the fevers and the other symptoms. So what we do most of the time when we get this done, the basic workup is all going to look negative, everything's going to look good, but what we have here is this leukocyte reduction filter. These used to not be part of transfusions. These filters, I'm going to make up some numbers here, they used to be like $10, okay? They're like, well, why add this $10 filter? when we give blood for those few that we need, well, one workup costs thousands. It makes sense to get the $10 filter. So most places now give glucose-reduced blood. It goes through a filter automatically because we've realized that those white cells cause so many problems. It just makes sense to spend the $10 on the filter. And of course, I'm making that number up because it's probably thousands and tens of thousands, right? You know, but the filter is way cheaper than a workup. TRALI, transfusion-related acute lung injury. This is kind of new, well, it's not new, but it was actually recently found and realized about 15 years ago. And for me, that's new because I'm old, okay? Transfusion-related acute lung injury. So what this is antibodies to granulocytes, usually in donors. So the donors are either multiparous females, women who have had multiple kids, or transfusions. But the FDA is actually considering allowing only male donor plasma. I don't know where that's at right now. I know as a female donor, they have tested me, and I don't have the antibodies, and I'm done having kids, and so my plasma is still okay because I don't have the antibodies to it. So there's some different rules out there trying to figure out how to keep it safe. But what happens is you end up getting these antibodies to these white cells, and then the patient's granulocytes are primed, usually some sort of bacterial infection, and this antigen-antibody complexes are going to clog up the lung capillaries. So biological, so you can see what's going on here. This should be nice and dark. Because I've all seen a chest x-ray, right? I should have a normal one up there versus this one. But normal x-ray is pretty dark, and when you have an infection, it gets like these white spots. But what happens here is the lungs fill with these antigen-antibody complexes. So think glomerulonephritis, how the antigen-antibody complexes hit the glomerulus. That's what's happening in the lungs. Basic transfusion, yeah.
Could TRALI be prevented using that glucose filter?
Yes. Yeah. Yep. Most of the time we're going to use it. Some still could sneak through, but we're trying to be careful. And it's actually, because usually it's going to be to the plasma they get that's causing the problems. It's going to be the plasma and not the red cells, and so it's not going to pick it up. It's going to be your own. It's going to be your own. Let me back up. It's most of the time going to be your own white cells reacting to plasma. So really, no. I guess in that situation, no. It could prevent you from becoming exposed and having the antibodies to donate. That one, okay. Basic workup is going to be negative. Pathologists may request tests for HLA antibodies in donor plasma. It's going to be a send out most of the time. If found, the recipient gets tested for the corresponding antigens. It's serious, but not usually fatal. They're going to catch it because some of those symptoms, and they're going to stop it and figure out what's going on. TACO. TACO is not on our initial list. This is one that I added. This is one that's come up even more recently than the TRALI. Transfusion-associated circulatory overload. So what happens is you end up getting pulmonary edema induced by blood products being transfused too rapidly or in excessive volumes. So you get too much and you end up in pulmonary edema. The acute onset or worsening of respiratory distress during or up to 12 hours post-transfusion. And you have to have two or more of the following. Evidence of acute or worsening pulmonary edema, evidence of unanticipated cardiovascular system changes, evidence of fluid overload, or elevation of the natriuretic peptide levels. So, two or more of these things must be in conjunction with respiratory distress up to 12 hours following transfusion. We have gotten much better about not shoving too many products at people too fast. Used to be, like I said, we used to give blood willy-nilly, and we give them lots of blood. And now we know we can't give it that fast. We can't shove it there. Your heart can't handle it. That it becomes pulmonary overload. It's fluid overload. So we've learned a lot in the last 10 years. So this really does not happen very often because we're not just like squeezing units in unless you're bleeding it out that fast, right? I forgot the kid's name. The first video I showed, he was losing it so fast, they could have like cut holes in and just put the whole bag in at a time probably and not had problems. But most people aren't gonna get it that fast. If they try to hurry, that's when they find they have problems. So it's like, oh, geez, we're supposed to close in 15 minutes and she's got a half a unit left. Let's hurry it up. Okay, that's why most blood is not given in clinic settings. I should say that's why. That's one of the many reasons. So TRALI versus TACO. I'm going to tell you right now, I don't really give you any questions on TRALI and TACO, but they're great board questions, so it's kind of keep in mind for boards. TACO and TRALI are both respiratory complications following a transfusion. TACO and TRALI are often difficult to distinguish in the acute situation, right? They're both difficulty breathing, distress with breathing. So looking at the patient, you're not going to be able to tell what's going on. TACO usually gets associated with hypertension and responds well to diuretics because it's circulatory overload, so we're going to get rid of some of that fluid. TRALI is often associated with hypotension, and diuretics aren't going to have much of an effect. On x-ray, we'll see the difference. When we look at a chest x-ray, if the chest x-ray is all white, it's the antigen-antibody complex. If the heart's inflamed, we're dealing with overload. Here's just some numbers. Don't worry about memorizing them. It's just kind of information of what we're looking for. These are this ejection fraction. I mean, these have to do with like heart things. Really, white cells, we'll see the white cells unchanged, transient, temperature unchanged, febrile, blood pressure up, blood pressure down. Basic lipid proteins, greater than 1200, less than 250. That's kind of the ones you're going to need to know about. Just kind of out of interest. This is more out of interest than anything. Don't worry about memorizing this. The big thing is just to know that hypertension with TACO, TRALI is hypo. And again, I don't have any quiz or exam questions on these. I probably should. I haven't added them yet. I don't think I put these in your notes yet, have I? We're still learning a lot about them.
There, tacos not.
Huh?
Trolleys there, tacos are not.
TRALIs or TACOs not. We're still learning about both. Is it pretty minimal though in your notes? I think I only put just a small amount in your notes about it, didn't I? So I'll add them at some point before I retire. Okay, in summary, does I have a hand up?
Yeah.
Yes.
There is one thing that, I don't know if you're about to mention it, but there's the transfusion complications masquerading as transfusion reactions in there.
We don't talk too much. Isn't that too much in there? Is there? The complication can lead to a reaction, so I think we're okay.
It's about half a page.
Okay. I'll have to like double check all that. What it's talking about? I don't even know what it's talking about without reading it right now. It's been a long time since I've read my own notes. I mean, I go through them every year, but anything in particular in there you think we should know? I don't think I have anything on quizzes or tests for you with that, so you should be good. All these things, until you do the actual testing in the lab, we always assume reaction. Because until we know it's not, stop the blood, and let's make sure we know what's going on. And even if it is a complication, stop the blood, give the Benadryl, watch the overload, figure out what the citric toxicity, all those things. We don't want to just keep plugging them with blood if they're having a complication.
If like they start to have like a small allergic reaction, we do the workup, it comes back negative, we give them Benadryl, can they then have that same blood, or do they
Yep.
need to have, okay.
Yep, once we give them that Benadryl, because chances are really good, whatever it was, they could be allergic to all of it. So once that Benadryl, usually it's good to go, and then future times, they'll just have a note in their file, give Benadryl prior to transfusions. And if you're gonna give me IV Benadryl, good night. So I don't know about the rest of you, I can't even do oral Benadryl without falling asleep. Okay, summary, transfusions, caution. We're not willy-nilly gonna give transfusions, right? We don't wanna just like give everybody, you get a transfusion, you get a transfusion. Anybody here old enough to remember Oprah's cars? So, everybody gets a transfusion, everybody gets a car, okay. I have to be careful, I start talking about things and over time, people go through these stairs like, what? Hemolytic transfusion reactions are very uncommon. We're not gonna see those very often. Acute intravascular or delayed hemolytic, we're not gonna see them very often because our testing is that good. Our procedures, all those quality assurance things we have in place, right? Going back to QA lab map. All those quality assurance things we have in place, our reagents are always the same, our racks are always the same, everything gets labeled, everything gets read in the same order, everything gets documented in the same order. Everybody documents the same, you follow your guidelines. All those things we have put in place are gonna help. So we really don't see these very often. When we do, usually it's a problem with pre-analytical collection or post-analytical bypassing all the bypasses. And even then, we don't see them very often. Non-hemolytic reactions, allergic and febrile are super common. We see those a lot. Actually, febrile is becoming less common now we're using this stupid filter, right? Febrile we're seeing less often now. Anaphylactic, TRALI, taco, uncommon. The more we've learned about taco, the less common it's gotten because it makes sense. Circulatory overload, duh, right? I mean, it makes sense. So now we know it's a problem. They've been a lot more cautious with it. Hospitals have in place blood usage committees. And in these blood usage committees, they keep track of, why is this, podiatrist ordering all this blood? They keep track of who's ordering blood, how much are they ordering, what are the thresholds for ordering. In the lab, if we get blood ordered on a hemoglobin of 10, a flag comes up and our pathologist gets notified usually, whatever the number is. We have different cutoffs in the lab. So if it's not a pre-op, like a pre-op sample, we're gonna get flagged, wait, we shouldn't be having to do 4 units of urgent cross-match here, things like that. Automatically notify your pathologist. I think I've talked about this before. There's always somebody above you, right? Did I talk to you guys about this? If you get a critical in the lab, for example, there's always somebody to tell, somebody to pass it on to. I had a former student who got fired. They got a critical bilirubin. It was the end of the day. The doctor had gone home and they went, oh well, and left. And she blames them. Well, everybody had gone home. But you should have known. There's always, if you don't call and tell somebody and document you told somebody, it falls to you, right? As you're learning, there's always somebody above you to call. You get something like this in the lab, get the pathologist involved. Get your lab director. If you don't have time because you're busy working, get the lab director, get them involved. If you're the last one at the end of the day and something looks odd, call somebody. You guys should never be the ones that take the heat for something. There should always be somebody above you to get a hold of. Issue no more blood. Don't say, well, can I have another unit? No, not until we figure out what caused this unit's problem so we can prevent it from continuing. Basic workup gets done on everybody, your clerical, your hemolysis check, your ABO, your DAT, everybody gets that basic first page. You don't just stop at any one piece, you do that whole first page. If it's all negative, most of the time you're good to go. You don't have to do anything further.